Okay, and I'm going to get us started off this morning. Good morning, everyone. Welcome to our final session of the Clinical Research Ethics Symposium for 2022. My name is Terry Fleming. I'm the Director for Research Ethics BC, and I'm joining you today with humility and gratitude from the traditional and unceded territories of the Lekwungen peoples, also known as the Wasanic, Esquimalt, and Songhees First Nations. I welcome everyone to add to the chat their recognition and respect for the territories on which you make your homes and or work. I would like to remind everyone that this session is being recorded for sharing afterwards for those that were unable to attend. And at this time, I'd like to introduce our moderator. Our moderator today is very well known to most of us that have been working with the research ethics community as Dorothy Herbert. Dorothy has been the Research Ethics Board Administrator at Interior Health since 2011. She holds a BSc in Dietetics from UBC and Master of Applied Sociology from the University of Tasmania, where she was a visiting scholar. And prior to her current role at Interior Health, she worked as a clinical research coordinator in nephrology at St. Paul's Hospital and subsequently taught in the CRC training program at BCIT. Please take time to read the bios of all of our speakers that are available through the link that is being put into the chat. So with that, I'd now like to turn it over to Dorothy and say it's all yours now. Thank you.
Thank you so much, Terry. Good morning and welcome, everyone. I would like to start in a good way by acknowledging that I am coming to you today from the unceded ancestral territory of the Syilx Nation, where it is snowing heavily, big chunky flakes, at least in my part of this territory. And if I had the eloquence of Sohalia that we were blessed to enjoy her opening yesterday, I know she would have something marvelously beautiful to say about it. And all I can say is it's a winter wonderland out there, so be careful if you're here. I'm really pleased to be a part of this event today and this presentation, where we're talking about research ethics from theory to practice. I'm in looking at the people who are attending, we have a lot of people who serve the communities in different ways. We've got research ethics board members and administrators and researchers, and some of us are a little less connected to research participants than the four lovely women who will be speaking today. So I'm eager to learn from them, to hear what they have to say, and to help you in the audience to have your questions answered. So without further ado, I would like to introduce Marie McClelland. She's a colleague of mine at Interior Health and is an experienced clinical research coordinator. And she is going to be talking about consent forms and delay of consent in a very particular patient population. And without further ado, I'm going to turn it over to Marie. Thank you so much.
Hello, everyone. Thank you so much for being here. I am going to start my sharing my screen, and start my presentation. So next slide, please. I would like to respectfully acknowledge my workplace is situated within the ancestral, traditional, and unceded territory of the Syilx First Nation, where we live, learn, collaborate, and work together. Next slide, please. So simplification of the informed consent form. Over the 20 years or so that I've been involved in clinical research, consent forms have changed quite a bit. And I think there's a few things that we need to be cognizant of as we move forward and incorporate some of the new recommendations that we are getting from our governing bodies. Next slide, please. So this poor little fellow looks really, really shocked. And that's the reaction I've gotten from quite a few patients when I present them with a consent form. What we're doing is communication of highly technical and complex specialized clinical trial information to participants with limited literacy, not always, but sometimes, diverse social cultural background. Absolutely, we hope that's the case. Diminished autonomy. We can't change the fact that they're there because they have a health problem, and debilitating diseases, which may be upsetting them, and that's all they can focus on. So we have to come into that situation and introduce the possibility of a clinical trial to them. I took this quote from a publication that Rashmi Ashish Kadam published in 2017. So complicated, lengthy, informed consent forms can be overwhelming. I looked at some of the consent forms that we currently have here in our department, and some of them are 15 to 20 pages long. When a patient is facing open heart surgery the next day, and they've got to go through a 15 to 20 page consent form in order to participate in one of our studies, that's a little overwhelming. Or conversely, a patient who may be asked to take part in a secondary stroke prevention trial, say. So you have, maybe 72 hours to longer to enroll them. But in the meantime, they're in a period of time where they need to be started on treatment. So there is a certain degree of urgency. And we're asking them to read this form, understand it, ask questions, sign on the dotted line, please, and then we'll randomize you. Next slide, please. So let's talk about the gorilla in the room. And by no means do I mean to say that Health Canada is the gorilla in the room, but the changes that have come down in the last, say, 5 years, but particularly in the last 2 years, has an impact. So I'm referring to TCPS 2 2018, Chapter 3, the consent process. So it is in depth. It clearly details all the elements that have to be in an informed consent form, and we can't ignore that. The problem is the interpretation and the implementation. So unfortunately, this results in an informed consent form that, yeah, it's 15 to 20 pages, and I've seen consent forms as long as 30 pages. It meets Health Canada requirements, and it perhaps makes the legal departments of the sponsor and the our governing bodies happy, but it's not easy for the patients to understand. And I think really we have to start focusing on that. Next slide, please. So strategies for simplification of the ICF, and this is not new for any of us that have been doing this for a while. We know that we have to have the wording in our informed consent forms at least at I think grade 5 to grade 7 level. There's another term which I can't pull out of my brain right at this moment, but they need to be in plain language, brief, direct. I think we need to try and keep the length under 10 pages. The use of pictures, diagrams, brochures, and information sheets to support the ICF. So if we shorten the ICF, then we can have this other material as support. I've had patients say things to me that, oh, I don't have time to read all of that, but I've talked to my family and I get the idea what the study's about. So yeah, I think I want to take part. Can I sign? So then we have to have that discussion where I paraphrase each section of the ICF. We go through it. I ask them if they understand each part of it. Some people are very accepting of that, and others feel like they're being spoon-fed. And so there's a lot of different ways or things that we need to consider when we're doing informed consent. And we need to understand that particular patient. We need to develop an understanding, a feeling of trust, because what I have heard more and more from people is that they don't want a 2-page explanation about how their information that they give to us is going to be protected in, behind firewalls and there's a lot of extra material that we are starting to put in informed consents that could be in a supporting document. Lots of different ways to approach this. I'm just saying we need to start listening to people and finding out what they think is necessary. They're the ones that are taking part in this research. Next slide, please. Next, I would like to discuss deferred consent in the context of acute ischemic stroke studies. And before we go any further, I would like to also stress that acute ischemic stroke studies should be considered in the same ballpark as we would consider a study for an acute MI or myocardial infarction. Remember, we used to say that time is muscle, well, time is brain. And or others, when I worked as a critical care nurse in the emergency department, I remember taking part in studies for cardiac arrest. And those patients, it was either waiver of consent, never mind deferred consent. Next slide, please. So as I stated, time is brain. A person loses 2 million brain cells a minute when they're having a stroke. And this is really, really important. Every 10-minute delay is associated with a measurable decline in the probability of an independent outcome. So what that sentence means, really, if you interpret that, is that it can make the difference between a patient recovering from their stroke and walking out of the hospital and going back to their own home, or a patient not walking out of the hospital and requiring a much higher level of care and perhaps having to go into community care. Those minutes really, really count. And the focus of acute stroke care is to restore circulation to the affected part of that brain. And it starts from the moment that the 911 call goes in or the family member decides, well, we've got to get to the hospital right now. Treatment, and there's, there are obviously accepted treatments, and the ones that are approved are the administration of a thrombolytic, which is a drug to dissolve the clot that is blocking the artery, or endovascular treatment, or EVT, where we mechanically remove that clot. I want you to think of a trauma patient or an arrest situation, a cardiac arrest situation, and that patient is being swarmed by a team of people who are doing everything they can to take care of that person. And I want you to consider that definitely stroke is a life-altering, potentially life-altering, life-ending disease. Next slide, please. So it takes 20 to 40 minutes to get informed consent. And anybody that tells you they can get informed consent in 5 minutes is not telling you the truth. There's no way you can cover all of that information in a very brief period of time. The other thing to keep in mind is patients who are having a stroke are often too incapacitated to provide consent, even if they're cognitively aware and able to obey commands and answer you. Consider what's happening. They're having a brain attack. Family members or their surrogate decision makers may not be available. They may not have arrived at the hospital yet, or they're too overwhelmed by what's happening to be able to focus on what you're trying to tell them about this wonderful research study that this person could be part of. And again, the takeaway message here, stroke can be devastating, and even minor strokes can be life-altering. And the only way that we can improve our knowledge and improve treatment for stroke is by doing clinical research and providing evidence-based therapies to improve care. Next slide, please. So with TCPS2, there's a whole list of conditions that must be met for using deferral of consent. So the researchers must prove that a serious threat exists that has to be immediately addressed. Research offers a realistic possibility of direct benefit to the person. They have to prove that the risk is not greater than what is standard care, and is clearly justified by the prospect for direct benefits. Participant is unconscious or lacks capacity. So obviously somebody who can't give you informed consent. And third party, so this would be your LAR, is not there in sufficient time to provide that consent. Next slide, please. So, no, that one, thank you. So the ACT study, which stands for alteplase compared to tenecteplase, those are the two accepted clot dissolving drugs currently in use in Canada. Alteplase was approved for use in stroke in the 90s. And recently we've completed the ACT study and are trying to get approval for tenecteplase to be widely accepted as an alternative. So the ACT study was a non-inferiority study. It was a probe trial, and you can see there what that stands for. We enrolled patients with acute ischemic stroke using deferral of consent. As I said, we compared these two thrombolytics. Patients would be informed if they were able to understand what the neurologist was telling them, but patient and or their family, it was accepted that they had appeared at the hospital with an acute ischemic stroke within 4.5 hours of stroke onset. Standard of care is to administer a thrombolytic. These patients, if they could understand, were told that they were going to be enrolled in the study and randomized. This was approved by Health Canada within the confines of this study and by our ethics. In the argument that was presented to Health Canada and to our ethics was, first, is the trial itself ethically justifiable? Is the use of deferral of consent methodologically necessary? And have steps been taken to minimize concerns regarding the effect of deferral of consent on individual patient autonomy? And all of those questions were successfully answered in a positive way. 1,600 patients were enrolled across Canada. Enrollment ended in January of this last year. And data has been collected on 1,577 patients. And I think that speaks for itself. It shows that most patients were fine with the deferral of consent. If they weren't, then they wouldn't have agreed for their continued participation for the 90-day follow-up in the study or for their data to be used. Next slide, please. So again, I think we need to listen to and engage our patient partners in the process for both simplifying the informed consent form and for using deferral of consent. I would also say that we need to go back into our patient logs and try to engage patients who have refused participation or patients who withdrew, as well as, asking people who have taken part in research or have just in the last little while agreed to be part of research, and ask them what their understanding of this whole process is. Do they have any suggestions to us? What are the pros and cons? We need to know what they are thinking because it's about them. And I think that the perspective of both groups could be very illuminating. And I think we need to consider adapting pragmatic strategies as demonstrated by the ACT trial when developing new protocols and informed consent forms. Next slide, please. These are my references, and I strongly recommend reading this article by Kadach. I found it very well written and lots of ideas in there that we could implement here. And my last slide. Thanks everyone so much for listening.
Thank you so much, Marie. That was illuminating. I know that there will be questions and I will be mindful of the time, but I just wanted to take a moment to acknowledge a couple of things that you said. First of all, your idea about creating support materials, so diagrams or brochures or information sheets, something that can go along with the consent form to keep the consent form itself short and to keep the language simple. And I would just add to that, that if there's a way that we can work with the sponsors who produce so much of the content and documentation to encourage more video, there is evidence to suggest that video consent, video augmented, there's thousands of examples on YouTube of how this works. And you know, as our population ages and younger people start aging up, you know, our kids' generation know nothing but that sort of thing. They would look at a 30-page consent form and say, you've got to be kidding. Where is the TikTok? So you are very aware of that, and it's part of what makes you good at your job. I don't see a question in the Slido yet. So I am going to just ask if you have any comments on how we can engage sponsors to help produce this material, or is there any other party that we could engage? Could Clinical Trials BC have a hand in this? Not meaning to put your colleagues on the spot, Terry, just thinking out loud here and wondering what Marie has to say.
I agree that definitely we need to start engaging with our sponsors, because ultimately they're the ones that send us the consent template. And it would probably, for the first little bit, mean taking more time to unpack that consent form and determine what could be condensed and supported by either a video or pictures. I saw an example of pictorial consent not too long ago. It was only a draft, though it wasn't a formal one. I can see someone's got their hand up, Dorothy.
Yes, that is Sudi from Fraser Health. So if you want to unmute yourself, Sudi, and please ask your question.
Thank you, Marie, for your fantastic presentation. This is something that we are dealing with every single day. I am, you know, just thinking a lot about the situation that we see from our REB administrator side. We emphasize that all of the documents should be consistent, for example, in the title and everything. And sometimes even the title of consent form, that is the title of the study. This is so complex for patients to understand. What are the meaning of those long, you know, title for the study? And we continuously ask them if they put something else. We ask them, please be consistent in all of the titles and everything. This is something that we need to think about. That I don't have you know, an answer for that, but I think all of us can think about that. How can we make it more understandable for participants? Even at the beginning of the, you know, informed consent, they don't understand the title of the study. Thank you.
Marie, if you have comments on that, please go ahead. And if not, we have a few options for questions here. So I will next go to Tanya, and then there's a question in the Slido. So, Marie, was there any comment on Sudi's?
No, I quite agree with what Sudi's saying. And we're not going to successfully change this overnight. This is going to be a year or two in developing consent forms that aren't 20 pages or more long, and giving a lot of extraneous information that really doesn't mean that much to the patient. They want to know, why am I doing this? What do I have to do? And who do I call if I have a problem?
Great points. Tanya, would you like to ask your question now, please?
Yes, Marie, thank you for the presentation. Just recently, I listened to one presentation presented by WCG, and they paid a special attention to the placebo effect. and how it influences on the results of research. And honestly, during my practice, I've noticed that this placebo effect starts from the moment we consent the patient, because I couldn't find the way to present the data of the study without my personal attitude to this. Any suggestions how we can minimize? So this is like from your experience, what you will be doing. I think that is why video presentation or some other technical support while presenting the consent might be a great asset, because it will be unbiased, right? And this is something else that we can probably explain to the sponsors why it is important to have this support.
So there's two sides to this. There's been a lot of research done on the placebo effect. For what my understanding is, it's usually not more than about 5%. And I think that's probably factored into the design of the study. And that's why we have that number of patients that they want to enroll. I would also argue that the placebo effect is a bit of an advantage to patients to being in a clinical trial. They get someone who can listen to them. They get someone who can sometimes help them to navigate the healthcare system. They get that feeling that they are doing something positive and they are being involved in their own care. It's not just being dictated to them. I think we need to be very, very careful that we don't lose that personal aspect and that whole idea that this is a trust relationship that we're building, where they trust us to have their best interests at heart. We don't know the answer to the study. We have equipoise. That's why we're asking them to be part of the study. But I think we also, yes, we do need to be careful that we don't put our own personal bias on it. Absolutely. But there's aspects that need to be maintained or kept into it. And I would say that personal relationship is very important. And I think that's why with us introducing e-consents, when we review the e-consent, we are there with the patient virtually going through the consent form with them.
Thank you, Marie. I'm trying to be mindful of the time here. So there was a question in the Slido, and then Penny has her hand up. And after that, we may need to move on to the next of our speakers. So from the Slido, the question is, what would you say would be a workable length for a condensed consent form? Or might a video be a good option?
So I think that, again, with a video, you don't want it to be longer than about 5 to 10 minutes. You got to keep people, I mean, keeping in mind your audience and who you're presenting this to. So if it's for an elective study where there's no time constraints about how quickly they have to be enrolled, fine. But for a time study where you've got 72 hours or maybe only 2 hours, in which to enroll a patient, you've got to keep it brief. As far as consent forms go, I would say 5 to 10 pages. Anything over 10 pages is starting to get to be a little bit long. And I've even had patients complain about a 10-page consent form. Oh, there's just too much for me to read. I'm too tired. I have pain, whatever. They have a lot of other things going on in their life, which is why you're talking to them in the first place.
Very good points. Penny, would you like to ask your question, please?
More of a comment. So thanks for that talk. I couldn't agree more. I just wanted to clarify that it's the interagency advisory panel on research ethics that develops and implements the Tri-Council policy statement. That's from the 3 federal research agencies. So it's my understanding that Health Canada doesn't have anything to do with it. So it's really the panel that needs to change their way of thinking.
Thank you so much for that. Yes, it is the
you're
panel.
Quite right. Quite right. I just oversimplified a little bit there because I went to the Health Canada website to get my information on the TCPS too. But you're right. And those are the people we need to start engaging with and with our patient partners. And I don't think it's going to be a short process.
And we have a comment from Jim. If I'm not mistaken, Jim might be a patient partner. Your name's familiar to me. And he writes, couldn't consent forms be worded in plain language? Yes, that's what we all want.
Yeah.
That might work more for patient partners. So consent of proxies would not be required. And I think Marie and probably many people in the audience and her fellow panelists all acknowledge that sometimes it's difficult. She works in a highly technical area. I worked in nephrology. It's just a little bit hard to simplify some of the terms there. Brains are complex, kidneys are complex. So we all do the best that we can. And I think that I can speak on behalf of my board and probably boards everywhere just to say we appreciate the efforts that the people who are working in those positions that Marie and others are in are making to try and make things understandable, to provide the best possible research participant experience. I'm going to move on to our next speaker because we've got 3 more presentations, but I will remind you that the chat is available, the Slido is available, and if I can see your hand, and people seem to be coming to the top of my screen to when your hand is up. So there's lots of ways to ask your questions after each presentation. And if we have time at the end, I would love for all 4 panelists to be up on screen so that any more questions can be directed at all of them. I know we're going to continue this great discussion. So for now, the next person that will be presenting to us is Tiffany Patterson, and she is a clinical trials coordinator at BC Cancer. And she's going to talk about deferral of consent from a different perspective, that of the problems created by distance. I had an opportunity to look at her slides and hear her speak one time before, and I know you're going to enjoy this one very much. So over to you, Tiffany.
Thank you, Dorothy. Those are some wonderful words that I need to live up to then, hopefully with this presentation. Okay, so I will just get these going. Okay, can you see my slides? Perfect, and hopefully not my presenter view. Okay, so again, thank you, Dorothy, for that introduction. So again, my name is Tiffany Patterson, and I'm a clinical research and trials coordinator at BC Cancer Victoria, specifically in the clinical trials unit. And today I'm going to be speaking to you about using deferred and remote consent in the context of patients with geographical and technological barriers. So just to start off, I wanted to just do a land acknowledgement in that I respectfully acknowledge that I live and work on the unceded traditional territories of the Algonquin speaking people, also known as the Songhees, Esquimalt, and Beecher Bay First Nations communities. So just to provide a bit of context about our unit for everyone, BC Cancer Victoria provides services to residents of Vancouver Island and the Gulf Islands, which makes up about approximately 870,000 residents. Within our unit specifically, there are 2 kinds of research that we do, and this includes clinical research, which is our non-interventional studies. And that involves things like biobanks, observational data research, and database research. The other type of research that we do is clinical trials studies, which is our interventional research. And this involves our systemic and radiation therapy trials. So in a perfect world, the standard consenting process for us would, with a patient, would usually follow this kind of a pathway. So you would meet with the patient in clinic, give them a consent form after their eligibility has been confirmed. You would connect with them later over phone or in person to see if they have any questions or concerns about the study, and then have them return the signed consent form in person and begin study-related activities. However, with more recently due to COVID and with physicians doing more telephone call appointments that we've seen some additions and also modifications to this consent process. And there's been an uptick in using remote consenting techniques to enroll patients onto studies. So mailing isn't necessarily a new form that we've been distributing consent forms, but now we're actually able to, at least at our facility, email consent forms out to patients instead of having to see them in clinic, which has really helped us reach patients outside of Victoria or who have those distance or geographical barriers. However, we are still finding that there are some sticking points when patients attempt to return their signed consent form to us. So just to name a few of the barriers that our patients may face include things like distance to the clinic. So as many of you may know, some of our patients do struggle with technology or they don't have access to it, which means that returning the form to us in person is sometimes the most optimal choice for them. Most patients that live outside of Victoria do experience these distance barriers, and this can include things like travel time just to the clinic, which is oftentimes just been a barrier for patients even coming into the clinic, is having to, sometimes they have to find someone who can actually drive them to the clinic, which can oftentimes be difficult. And also the funds that they have to spend on things like food, gas or ferries, and sometimes even accommodations. And some of these studies do reimburse a portion of these expenses, but that's not the majority of the studies that we run. A second barrier that our patients face is returning a consent form in a timely manner, especially if an eligibility window for one of our trials or our studies is closing. So mailing can oftentimes take too long for the consent form to come back to us. Fax machines are often difficult to find, and sometimes, for example, if you go to Staples, sometimes their fax machine isn't necessarily reliable, and scanning an email emailing them back to us also has its problems. So for example, we've had it where sometimes only a portion of the consent form comes back to us. And that means that the patients then have to find time in their day or in during another day to redo that whole process over again. So unfortunately, we are leaving some of these patients to their own devices to figure out how to get that consent form back to us, which can leave them unfortunately feeling discouraged from even enrolling. And as a nurse coordinator from our unit said to me when I was discussing this with her, we're making things harder and we're not setting these patients up for success. So what might be some solutions for overcoming these barriers? So the first of many solutions that I just wanted to highlight is e-consenting. So specifically REDCap, which for anyone who might be unfamiliar with REDCap, this is a secure web app used for building and managing online surveys and databases. So this is something we've actually been able to use in a few of our non-interventional research studies, so like our biobank studies, and it has simplified the consenting process for many of our patients. The other secure web app that we currently use only for housing and managing our clinical research and clinical trials is Realtime. This app, along with REDCap, are two secure apps that we're hoping we'll be able to use in the future for consenting more tech-savvy patients specifically to our clinical trials. We can also use these not just for initially consenting patients, but also for reconsenting them when we have things like protocol amendments that come up. And this would be especially useful and would lower the travel burden load for patients that are in follow-up and not coming into clinic anymore for their appointments. So for example, like if we have a patient who lives up in Powell River, who's been coming down for treatment, let's say that they go into a follow-up process and they're doing telephone appointments with their physician. If we just get them to come down to clinic to reconsent onto a protocol amended or an amended consent form, that's quite a big ask of them. And so using these secure web apps would actually be very beneficial for these patients. The second solution that I would see especially for patients that aren't as tech savvy, would be deferred consent. And this type of deferred consent would be used a bit differently than how it was used in Marie's presentation previously. So these wouldn't necessarily be used in like emergency type of situations, but we wouldn't wait for the consent form to come back to us before conducting clinical trial related activities. So it would be more like deferring the formal consent or delaying a consent, as Dorothy said previously, and this would probably be coupled with some type of verbal consenting process. I would think that this would work more in the pre-screening or screening phases when we're determining if a patient is eligible for a study or not. And how I specifically envision this is being able to verbally consent a patient and then conduct trial-related activities like ordering imaging or shipping out their archival tissue for testing, or even ordering blood work before the signed consent form has been returned to us, but that the patient has verbally consented that they do want to participate. And with some of the barriers that our older demographic or our less tech savvy demographic may face, this option would be optimal for them in helping them enroll more easily onto a trial. So I kind of call it deferred formal consent, or you can call it delayed consent. But so why would we want to use this specifically? So as mentioned previously, this would be easier for people who aren't tech savvy, which is oftentimes, but not exclusively, our older demographic. And this would also lessen the burden on patients to have to use resources like time and money to appear in clinic to finish the consenting process. And I know that distance barriers for patients is not a problem unique to our center. I know that many centers also struggle with this. So having options for these patients that makes the consenting process easier is really helpful for them. And that framework could be applied at other sites. And I really believe that this would remove barriers and open the door for people in more rural or remote places who might not have access to the internet or access to a smartphone. And being aware of that and addressing that with accommodations allows us to be more inclusive of those patients and their needs. And I think that having a type of deferred formal consent in place would not only make the process easier for those patients, but also encourage them to participate in research and trials. And thank you for listening. That's all.
Well, thank you, Tiffany. I don't think that will be all, because there are already questions and comments popping up. So I'm just going to start by saying, first of all, you absolutely lived up to the introduction with that. I really liked in particular your solutions-oriented thinking. You gave our audience members a couple of practical things that they can perhaps apply in their own settings. And, you know, we know that BC there are thousands and thousands of people who live in rural and remote areas. It's the curse of living in a beautiful province, I think. And so we need to think about how to make life in BC fair and equitable and appropriate for them when they're facing such a difficult time. And I have such confidence that there are people like you and our previous speaker, and no doubt our next two, that are doing what they can to make that. I really liked your comment about setting participants up for success. If I ever return to the role of clinical research coordinator, that is going to be my job description. And finally, I really am encouraged that real-time and REDCap are good options for tech-savvy patients. And one could perhaps expect or hope that a greater proportion of the population over time will be comfortable with using that. And from an RED perspective, we love that. We are so concerned about data protection and privacy. And you know, a fax machine, we just, again, referring to my my children who are just at that age where they are old enough to be incredibly tech savvy. One's in studying at university, and yet young enough to say, "What's a fax machine?" Because they've never seen one. So fax machines are not always a good solution. I am going to get on to other questions and comments This one popped up first from Manny. How does the timing work for remote consenting and signing of paper consents? Do you wait, or do you need to wait until the site has received a copy of the signed consent form from the participant before study assessments can begin?
Yes, so we actually do have to, at least at BC Cancer specifically, we do have to receive that signed consent form back from the patient before we can start any trial-related activities. And technically, we're actually supposed to wait until we've received it, made a copy, and then the patient has actually received their copy back for any trial-related activities to start.
Thank you. We've got questions popping up all over the place. So I'm going to try to get to both the Slido questions, and I see a couple of hands up. So Sarah writes, I would appreciate hearing from REB members and reviewers thoughts about why deferred consent as presented here might not be possible. So it's a general question. I guess I will look to the audience to see if there are any commenters on that. And I don't know what Marie or Tanya. I can't see everybody all at once in this view. So if there's a hand up, then I don't know. I might have to put a pin in that one, and I'll come back to it. I'll ask Aoife to not delete that from the Slido if that's possible. We should have time at the end. Thanks, Sarah. So I have a couple of hands up, and I don't know what order they came in, so I'm going to go in the order they're on my screen. Marie, you have a question or a comment?
Mostly just a comment, and I'd like us to consider more often using verbal consent. And I know there's a lot of security issues around that, because sometimes we have to have it witnessed, but that can be insulting to patients sometimes, saying that you have to have somebody witness their verbal consent over the phone. Getting that verbal consent recorded and then downloaded and saved securely is also an issue. And we went through all of this when we were first slammed with COVID. But I recently had a patient say to me, if all research is voluntary and I can withdraw at any time, I'm already telling you I want to be part of this study. Why do I have to sign this form? She did sign the form, but that was her point.
Thank you, Marie. In the interest of time, again, I have a wonderful suggestion here. If perhaps we can be sure to add any questions to the Slido for at the end. Questions that aren't addressed won't be deleted, and then we can carry on. But Tanya had her hand up, so I'm going to take one last question from her, and then we will carry on.
We can leave it for later if you'd like, because there are two questions, unfortunately, and I definitely need a suggestion and Tiffany's experience. So one is about the electronic, like e-consenting. Have you ever heard any refusal from the sponsors, where a majority of them okay with it? And second question about deferred. It's a great idea, but my concern is, because you mentioned that deferred consent form can be used for some pre-screening activities that could be done. So I understand that, let's say, imaging or like lab blood collection is done in the facilities in Powell River. So patients don't need to come to Victoria in order to do this. So how do you organize it technically? Because this is my struggle. I have patients traveling from all over Lower Mainland to Burnaby Hospital, because otherwise I need to list all these organizations in my 1572 form, for example. I need to collect all the normal ranges, all CVs, and etc., like a bunch of the administrative paperwork. So how do you organize it? Thank you.
No worries. Okay, so the first one was about e-consenting, and have we asked sponsors if we can use that?
Are they usually okay with it? Because I don't know.
So at least I don't know even if we've brought it up with sponsors specifically, or there's kind of like, because we have sponsors who are like stakeholders in it. We have BC Cancer, our privacy, and then also REB. So I don't know if that has actually been brought up specifically with sponsors to see if they're okay. And actually, I just wanted to do a little side note, because I do know that some of our sponsors, I've seen for, I guess, informing patients about a trial or something, they have provided videos for us, but we haven't been able to get that pass through REB ethics. So I don't necessarily know if the e-consenting using for clinical trials purposes for interventional based studies, if that's a barrier with the sponsors, or if that using e-consenting, if that's a barrier with the sponsors or barrier with REB. We've only been able to use the e-consenting specifically through REDCap or real time with our non-interventional research studies. But I do know that actually one of our, I guess, managers, she manages real time for us at the cancer clinic. There's actually going to be discussions with REB and privacy about actually using real time for clinical trials. So this kind of in the works, but I don't necessarily know if it's more of a sponsor that's showing those barriers for us, or if it's REB or privacy, but there's talks about it and hopefully getting that moving. And then your second question was with using verbal consent?
No, so it was not so much about the consent itself, it's about everything else that comes with it. So for example, for industry-sponsored trial, I need to list every facility that participates, and I need to provide a bunch, like I need to get data of calibration of the equipment. So I'm the coordinator responsible for normal ranges for all the labs. Lab manager CV, I need to get data about the equipment and etc. So when you mentioned that you have patients living in Gulf Islands, Powell River, and they, instead of bringing them to Victoria, I understood that they can do some of the tests locally. How do you include all these facilities?
Okay, so I guess so. Usually, at least for any of, so like how, like if we had someone, let's say in Salt Spring Island, and they wanted to get their blood work done in Salt Spring Island, how would we include that?
Yeah, because as I understood, this is the whole idea of deferred consent, that they can do some pre-workout before actually coming to your center in Victoria.
Oh, okay. So I guess that it's more in not like the blood work that they would be able to do. Let's say that they could do it in Salt Spring Island if it was a local lab, that we could use those results. That would be something where we provide the DAP certificate to the sponsor. We provide them with the local lab ranges, and then they're good to go with that. The imaging and I guess like the archival tissue that I was thinking of, that's more just ordering it and getting those dates set in place so that the patient wouldn't fall outside of the eligibility window. It wouldn't necessarily mean, because for example, like if we'll do CT scans, we have to do those in Victoria. And so they would have to come to Victoria anyways, but with the huge load on our healthcare system that's happening right now, sometimes we can't schedule those in like within an eligibility window, let's say, or they're outside of the window. So we would at least want to have that deferred consent while the patient's trying to get the consent form back to us, and then have a placeholder time for when they would be able to do their imaging instead of having to wait a week and then book their appointment. And even sometimes, let's say even with like archival tissue, if a patient had their biopsy done up in Nanaimo or something, sometimes it can be difficult just to get that tissue ordered and sent off to the central lab for testing. So it might take some time. And if there's a week delay, that could have them fall outside the eligibility window. So it's not necessarily that they would be getting, they could be getting the blood work done, but not necessarily that they would be getting the imaging done, but that we would be able to have a placeholder time for that. So yeah, that's kind of how I'm envisioning it. I was talking with my nurses about this because they are actually usually the ones who consent for our clinical trials because it is intervention based. And we were trying to figure out like, okay, how would this work and how would it make this easy? And that was kind of what we came up with, was more having those scheduled times, and so they don't fall outside that eligibility window.
but you're not getting away from adding Island Health plus the Salt Spring Island Lab plus the lab coordinator CV plus all of that you're talking about, Tanya. So it's not really like, there's definitely that piece where all of the documentation needs to be captured to add those remote participating sites to make sure that the information you're getting from them qualifies for pre-screening purposes. And also, while I'm talking, just to add to the other part of the question, my name's Heather. I'm the manager for PHSA for the clinical trial management system. And so what Tiffany's touching on related to e-consent is near and dear to my heart. And we're about to, initiate some of these discussions with REB to see how to move forward with this. And to answer your first question about sponsors, is this a barrier for them? What do they think? The sponsors have actually been coming to us and saying, we have a platform, can we use this? And we say, oh, sure, that sounds like a great idea. Let's see if we can get it through privacy and ethics and get all of our ducks in a row. And by the time we get approval, the study's closed to accrual and it's too late to use e-consent. So what we're looking to do is build our own homegrown solution with preemptive approval where privacy, security, ethics, everybody has an opportunity to weigh in and make sure that it ticks all the boxes, so that when the sponsor comes to us and says, we'd like to use e-consent, we said, yes, so would we. We have a platform that's approved here, and this is how we'd like to move forward with it. So that's the next step in that discussion. I just wanted to throw that in there. Thank you so much.
Thanks, Heather.
There have been so many great ideas, and I'm so encouraged by what I'm hearing. I am very aware of the time and how much interest there is, but there's one more question, Tiffany, that I thought would be appropriate for now. And then there are some that are going to hang around in the Slido until the end. And I apologize to those people who are waiting for a little bit. They mostly had more general questions, but this one specific to your talk, if you are mailing or emailing a consent form, how do you ensure that the participant understands the study?
So after it's been emailed or mailed, usually either the research coordinator or the nurse will wait about a week and then give the patient a call, and they'll check and see if the patient has gone through the consent form. And there's usually then a process of going through each section to make sure that the patient does understand it. And if they are going to be mailing the consent form back to us, let's say, they do have to schedule a telehealth, not necessarily a telehealth, but like a Zoom meeting with the patient to watch them sign the consent form, etc. And that also does open up the area for consenting. And when we do consent patients as well, we do kind of, like as Marie said, we give like general summaries to each of the sections, and at least like the important sections, so that the patients really understand the main focus of the study. And you can withdraw at any time that you want to. These are the privacy things that are going to be taking place to make sure that your patient information remains confidential. So we do take as many steps as we possibly can, and then open up the ability for the patient, an opportunity for them to ask questions as well. So.
Terrific. Thank you so much, Tiffany. That was a stellar presentation, and I'm looking forward to the next two. So we are going to move on to Camille Galloway. Camille is here at Interior Health, where it continues to snow in the territory of the Syilx people. And she's going to be talking about access to patients as clinical trial participants. And I think drawing on an anecdote that happened here in Interior Health that was very collaborative with different appropriate departments. So I'm thrilled that this is what she's chosen to share. So on that note, I'm going to turn it over to Camille.
Hello, everyone. Let's see if I can share my screen here. Okay, can you guys see my screen all right? Perfect. I love when technology works out. Okay, so thanks, Dorothy, for the introduction. Just again, my name is Camille Galloway. I'm an RN and a clinical research coordinator in Interior Health, Kelowna General Hospital. And today I'm going to be talking to you guys about ethical considerations when screening patients for clinical trials. So before I start, I'd like to respectfully acknowledge that I live, learn, work, and play within the ancestral, traditional, and unceded territory of the Syilx Nation. So as you can see, Interior Health Clinical Research Department services quite a wide range of areas. So we do have units both in at Kelowna General Hospital, Royal Inland Hospital, which is in Kamloops, and Penticton Regional Hospital. And we're here in Kelowna, we're a full service outpatient clinic. We have a lab, a medication room, and patient rooms, and we're staffed with coordinators, nurses, and pharmacists. And we really cover a range of specialties in a bunch of different types of trials. So cardiac, neurology, renal, just to name a few. So since we run such a wide range of trials, we are really present in many areas of the hospital and outpatient clinics. And our research team really becomes very close with the staff and physicians on the units or in the clinics, and we interact with patients on a daily basis. So as I'm sure everyone here would agree, we know that research is beneficial for both patients and staff. So for example, it provides a lot of education, again, for both clinicians and patients. So patients are able to spend more time with clinicians, learning about their condition, and have more time to ask questions. And in terms of clinician, they really get the opportunity of seeing research into action and participating in trials that have the potential to change acute care practice, clinical decision-making tools, and patient outcomes. And clinical trials really improve care by leveraging staff education opportunities, and it really reinforces long-term goals and health system improvements. And again, as mentioned before, it's great for patients and they get access to the newest available treatments and care. So despite the well-known benefits of research, getting a research study up and going can be really time consuming, and the process is not always pragmatic. So by the time you get going, it's really important to hit the ground running and get patients into your study quickly if possible. And unfortunately, we face many barriers for recruiting and screening patients. So when I first started at KGH a few years ago, I'm just going to talk about what was our process for screening on the wards and then screening outpatients. So for screening on the wards, we were actually required to approach staff on the units to determine eligibility prior to approaching the patient. Or we could approach the patient, ask them for their permission to look at their health records. Then we would go back to look at the patient's chart. At that point, we would determine eligibility. Oftentimes, the patient was not eligible, and then we'd have to go back and let the patient know they were not eligible. So that was very time-consuming, and again, kind of confusing for patients. In terms of screening outpatients, we have to ask a staff member from a clinic. So this takes time out of their very busy day-to-day clinical practice. We have to ask them to call patients to request permission for them to give us permission to call them and speak to them about a study. So again, at this point, we do not have access to their records. We don't know if they're eligible. We can give them a call and request access, and then we might have to call them back again to let them know if they're, oh, sorry about that, if they are eligible or not. So the process is really, again, is really time consuming. It's costly for researchers, it's unhelpful for patients, and it's not always feasible for other clinicians that are involved. So like any really good top of the line research team, our interior health group, we sat around and complained about it for about 2 years before doing anything. So the question we asked ourselves is restricting researchers' access to records for pre-screening purposes a detriment to patients? Is it ethically correct to not offer everyone the chance to participate in a trial because of these barriers? And of course, as I'm sure you guys know, this is very straightforward yes or no answer. And of course, I'm joking here, but it's really a multidimensional problem. It involves multiple players that have been mentioned in previous talks here. So privacy, ethics are involved, legal, the research team, and the patients themselves. So after speaking with different groups, we ended up consulting with the privacy department regarding access to patient records. And we were seeking approval from the Interior Health Information Privacy Department to allow clinical researchers access to patient records for pre-screening purposes. And so after meeting and meeting many more times afterwards, the privacy department came up with the following conclusions. So CRCs, or clinical research coordinators, did not meet the basic definition of a patient circle of care. However, IH staff accessing patient records for pre-screening purposes to determine eligibility for a study prior to contacting a patient is not in contravention of BC Freedom of Information Protection of Privacy Act. And so as employees of IH, our department is now able to screen patients, inpatients, in a more pragmatic way. But this still leaves many questions unanswered, and there's still barriers. What about external researchers or outpatients? So it doesn't really answer all of our questions here. So another thing that was really important, again, coming back to the same question, and is arguably more important, what do patients think about this? What do they want us to have access to their, do they want access to clinical research? What do they think? So in February 2021, the Patient Partner Committee wrote a letter to the Premier titled Patient Partner Clinical Research Concerns and Recommendations. And they represented a wide range of experience and expertise in numerous aspects of the healthcare and research systems. And they felt that because of that, they were in a unique position to both understand and represent patient and public concern. And so the reason for their letter was to help facilitate changes that they believed were urgently needed in order to optimize patient care and enhance overall operations of clinical research within the BC healthcare system. So one of the things they wrote, they said that research is care, and it should be seamlessly integrated into the clinical setting. And they also wrote that their personal experiences have shown that majority of them would be willing and eager to be involved in a research study. So they also provided some recommendations, and one of them was that access to clinical research should be widened, with all areas of the province being actively encouraged and enabled to contribute to this essential work in order to ensure equity of access of clinical trials as a core component of patient care. So kind of in conclusion, clearly there's a need for all parties to discuss how to best, one, give patient access to clinical trials, and two, allow researchers access to patients. And it seems like there's a will from both patients and researchers to do this. And ultimately have these discussions is only really going to serve to improve the health and well-being of British Columbians. Thank you.
Thank you so much, Camille. That went really quickly, I think, because I was enjoying myself. You present a topic that could be challenging for a lot of people to talk about, and you did that with humor and grace. So thank you for that. I had a couple of, I've lost them. They are a couple of thoughts. that I wanted to share, and then I will be looking for questions. I don't see anything in the Slido at the moment, but I expect they will come flying in. And I just wanted to acknowledge that you talked about institutional barriers to conducting research, and you also, as your previous speakers did, you presented possible solutions, and I think that's how we get there. And it's nice to know that people are all looking for solutions and not just saying, well, we don't like this. So that is what you and your colleagues have done. And a shout out to our privacy team who were instrumental in this. I did see our privacy lead from Interior Health online yesterday. I've been a little busy this morning, so I don't know if he's here, but if he is, great work, because he was a principal collaborator and actually drafted the brief that laid out clearly something that worked for clinical research coordinators, that the REB was happy with, that worked for the patients. And just a last thought here, I love your patient-oriented focus. We have been hearing about patient-oriented research for, I don't know, years and years. But it's one thing to hear about it, and it's one thing to see it in action. And we see that with you and the way that you have approached this problem, this solution, and the patients who become your research participants. So I'll take a look in the Slido, and I am only seeing questions from the previous one. So, oh, look at this. Thank you. Sarah's made a comment, and her comments are always worth sharing. Access to research is also a determinant of health. I heard Dr. Caron, that would be Dr. Nadine Caron. I think many of us have heard her, fantastic speaker from Northern Health. And she has said that this last year, in regard to access for rural and remote communities, which can include Indigenous, it is a huge equity issue. Yes, and that is something I think that touched on the last speaker's thoughts too, and all of them. I think they're weaving. I don't know if you guys talked about your slides in advance, but you're weaving this very important patient-oriented focus and equity issues throughout your presentations. It's lovely to watch. And there's another comment in here. It would be great if privacy offices of the different health authorities in the province can start some kind of harmonization efforts. I know that the Ministry of Health is interested in this topic, which is as high a level as we go in this province. So I don't know, even if I knew more, I don't think I could say more, but that's about all that I know right now, other than to say there's interest. There's a tremendous amount of work being done by Terry and her lovely, lovely team at Research Ethics BC. And they're part of the larger Michael Smith Health Research BC. So if I can just be indulged to put in a plug for them, I know that this audience knows about them, but sometimes they're not the first people that come to mind. And just this morning, before we started, I was able to answer a consultation request by referring someone to Clinical Trials BC. I know the people there have more expertise to answer the particular question than I had, or that might be possessed in my immediate circle here. And so I can't say enough good things about the whole Michael Smith Health Research Group. So please be aware of that. And I'm still not seeing more questions in the Slido as of yet. So I think that this would be a great time to move to our fourth speaker, because the way that your presentations have flowed together so nicely, that will allow us a bit more time perhaps at the end for all four of our panelists to be up on screen, take me out of there, and have some questions. So without further ado, I will introduce our fourth speaker for today. She is Tanya Kadach. Pardon me if it's not a hard C. I'm Slavic, so I look at that and that would be
It will be
definitely a part.
It will be Kadach, but it's okay. So
Okay. One thing I should have checked before.
don't worry.
And she is also a research coordinator from Fraser Health. She's going to continue to illuminate us on topics of interest in how research ethics goes from theory to practice. And she has a vulnerable case studies sort of segment of the population that is near and dear to my heart, because I have a couple friends who fit in this population. So I'm eager to hear what she has to say. So welcome, Tanya, over to you.
Thank you. Okay, I'm sharing the screen. Okay, share. Okay, can you see my screen or presenting mode? All good? All good?
All good.
Okay, perfect. Thank you. So today I would like to probably finalize our presentation, as you mentioned, and it's research ethics from a site perspective. As we've heard from previous presenters, although each site is unique and we have different needs, some clinics are small, some organizations are larger, some of their difficulties that we experience, they're the same. And I'm glad that we have this discussion and can come up with some solutions. I respectfully acknowledge that I'm connecting from the ancestral, traditional, and unceded territory of the Coquitlam First Nation. We thank the Coquitlam who continue to live on these lands and care for them along with the waters and all that is above and below. So I work in the Fraser Health Multiple Sclerosis Clinic that is located in Burnaby Hospital, and the clinic was established in 2004, and now we provide care for more than 4,000 patients living in Lower Mainland. And so currently we have 5 neurologists, 3 MS nurses, 2 study coordinators, and many administrative staff. And since opening, we have conducted 60 industry-sponsored clinical trials, grants, multiple clinical improvements, and investigator-initiated trials. As though, probably as all of us know, who have any family members or loved ones who have MS, there are multiple therapies available currently on the market. However, all of them have some kind of limitations with the coverage. And there is, my favorite one is age of 55. It's as if after 55, we don't live, quality of life doesn't matter anymore, and we don't need any other treatments. That is why we try to select the trials that really benefits our patients. And we have many progressive patients that currently don't have any therapies available. That is why probably our research was opened and is actively working for so many years. As you can see, community is stronger than a disease. So we need a lot of people who can help in this process. A little bit glitchy video. So, but you can see that we have a study site team, we have RAB team, we have patient and patient family, and then the sponsors. So definitely each of these groups, they have their own expectations, needs, limitations, and all of them we need to take into consideration. If we briefly look at the life cycle of a clinical trial, I divided it into four main phases: startup phase, maintenance phase, study closure phase, data archiving and storage phase. There are several tasks that needs to be resolved at each phase, and as you can see, there are many question marks for all of them. This is what I would like to show, that on each phase we have ethics involvement. And by ethics, I would like to mention not only the people who are participated in your project review, so research ethics board in particular, but the whole support team that helps with the contract approvals, with the privacy reviews, with your departmental agreements, establishments. So in Fraser Health, we have Department of Evaluation and Research that was very actively involved in all the aspects of the clinical trial maintenance and setup, and helped us tremendously. So as you can see, there are these multiple question marks. I would like to identify that on each phase, site will have questions. And first people with whom I will connect to try to address and find solutions, that will be people from research, because they have not only expertise and knowledge, but they at least can provide some guidance where to go. Like Dorothy mentioned, connect with clinical trials BC. So something like this. We need to know from where to start. Like for example, during data archiving and storage phase, we all know about the change regulations that records retention period in Canada has been switched to 15 years. However, when I connected with my sponsors, at least 3 of them said that, sorry, but for our local policies, we will still would like you to keep all the records for 25 years. When we think, okay, 25 years from now, will my PI be still there? Will the site be open? What are we going to do? And I don't have an answer. I will connect with our research team to discuss it. However, there are several things that I would like to bring to your attention. Something that I think needs to be changed and improved. One of them is unified standardized research processes between different resources and institutions. As you can see, it's the same call as we just heard from Camille. She mentioned about the privacy department review. Tiffany previously mentioned about CTMS or real-time and e-consenting. And it will be absolutely terrible if each authority will need to go through this process separately, because we're all using the same systems and we all have the same questions. So if it is going to be resolved at Vancouver Island, why not to have it implemented in Fraser House right away? And here I would like to mention, so it is not only privacy issues, it comes to EMRs, something that was discussed yesterday during the presentation that was done about machine learning and artificial intelligence, that we cannot use efficiently the data that we have because we don't have access to it. So currently I have a patient who is hospitalized in Vancouver General Hospital, and hepatologists couldn't see records of the labs tests that had been done in the Burnaby Hospital. They have to repeat the same test again, that are all costly, that all takes time, and the care is definitely delayed and not provided. At the same time, I need to report to the sponsor on everyday basis what's happening with the patient, because the patient is due for liver transplantation. And we cannot reach the physicians, and I cannot even see what medications are prescribed to this patient, because I have only lab works results and nothing else. It's really important, not only for research, but also for the clinicians, I think, to have these processes in unification. If we speak about normal ranges, lab departments and CVs, for example, in Burnaby Hospital, we have only 2 active research clinics right now, like Fraser, like multiple sclerosis and oncology. I need to come to my lab manager and ask for the calibration records and for normal ranges and for these CVs on yearly basis. The other clinic will do the same. Why not to publish everything on one web page so everyone could download it from there? Why these normal ranges cannot be the same for all the clinics in Fraser House, if not for the whole BC? So this is what I think it is important, because then we wouldn't need to reach each laboratory or each imaging facility and get all these multiple documents, and has extremely long setup process. And next one is bring awareness of the RB requirements. What I've noticed that, for example, in Fraser House, we have all the guidelines and documents published on the webpage, and I definitely know where to go and where to look for them, probably because I have been working in this role for so long. However, when the sponsor comes to me and says, okay, Tanya, tell me, do we need to submit for the RB review this particular manual, memo, guidance? I don't know, because I don't know what documents needs to be sent, what needs to be acknowledged, and which one shouldn't. So if there are some changes, it would be lovely to hear about them. It would be lovely to hear about RB expectations about the site and what they need to do. And suggest a couple of probably one webinar per year would be great. And last one is increase the frequency of the board meetings and shorten review times. As you've heard from the previous presenters, time is extremely important. It's not only about that some patients are in emergency situation and it needs to be provided in timely manner. It's also because recruitment period is very, very short. And I understand that it's probably the balance that needs to be found, because like in Fraser Health, there could be multiple submissions that needs to be reviewed in December and then not a single one in January. And you cannot have board meetings every 2 weeks probably as a result of it. Resources, another issue. However, with the requirement that we have right now that board is meeting every month and we have 3 weeks, so the documents needs to be sent 3 weeks in advance. Let's say if protocol amendment documents came 2 days prior to this end of the submission period, it means that I'm not in time to submit for this meeting and it will be already delayed for 2 months. So by the time we have approval, letter of authorization, very often some countries, sites in Eastern Europe will recruit 20 patients already by the time. And this, again, limited, very often missed opportunities for our patients. Like this summer, we had very important trial, very promising. Up from the approval to the end of recruitment, we had just 1 month. And we were able to involve the patients at our site, but we received so many calls from neurologists and patients from Alberta and Saskatchewan because we were the only site approved in Western Canada, and they really wanted to come because it was very, very unique treatment, and we couldn't offer this opportunity. So really, this will make a change. I had experience working with central RB and with local one, and I just would like, probably it would be lovely to learn, and our local RBs could get some, benefits from the central one. So review time, definitely, unfortunately, the same question. And main submissions are done by the sponsor. So this is like the privilege. This is something that we benefit because the sponsor will, we don't need to spend time on it. However, all the setup is on the shoulders of their coordinators. We need to look for providers like pharmacy and lab. And I found it was very difficult to find this live support. It was challenging to connect with the clinical trials BC to ask for questions. So to have particular person who can help you. With the local ones, I'm spoiled, I know, but this ongoing support that was provided over the years by our Fraser Health, their department, it was tremendous. Also, definitely our site has a privilege and opportunity to work with other departments in the hospital, and this is what makes us so much beneficial in comparison with many other sites, I expect. And having this local RB gives the opportunity for PIs to present their own projects at the meeting. So for example, instead of spending months on the modifications memos that are sent back and forth, the project can be just presented and the questions answered right away. To finalize this presentation, I would like to share my vision of the ideal RB. So first criteria, it will be lovely if it should be alive. It means that with all the technology in place that we have right now, we cannot really transform this function to some portals. We need to have people who understand the reality of the clinical trials, because they need to be able to respond to individual requests from the sponsors. Like example from a month ago, 6 protocol amendments in August, 6 approvals in September. Out of 6 sponsors, just 1 didn't like how the certificate of approval looks like. And they wanted us to create a note to file. So Sarah, please, you have half an hour because we have a patient coming tomorrow and we don't have a green light. I wouldn't be able to do it with the central RB. Decision making. This is to go back again, like right and wrong decisions. A couple of years ago, we had a study. We applied for approval for study extension. However, efficacy data was not available at the time. The patient that we had, we didn't know at the time, studied drug or placebo, but the patient felt extremely well. And definitely the site team wanted the patient to continue. However, approval wasn't granted because of the efficacy data. It was provided only in a year. Patient had to wait. The medication was restarted in a year, and definitely it wasn't the same effect. Patient progressed within 1 year from the walking with a cane to walking with a walker. It's a lot. So when such decisions made, I understand that ethics team would like, they need to make a decision keeping all these parties involved. So I think patients probably call needs to be taken into consideration this time, neurologist point of view. Just things to consider. As soon as possible. We're all aware about this formal process that we need to follow, like Tiffany mentions about the consenting. However, sometimes safety of the patients, we need to make decisions quite quickly. So for example, we cannot always wait for the protocol amendments approval and formal reconsenting of the patients. For example, for one of the studies, we had additional lab assessments that need to be conducted to have additional liver measurements to make sure that liver enzymes are not increased. And we just needed to, so RB was informed, so the safety memo was sent, patients were informed, and we started making these changes without waiting for the protocol amendment. And availability, I know that all of us need vacations and we all need to be sick and have time off, but I really as a site would like to make sure that there are enough people in the research team who will be available. So in case if we have all this urgent individual requests, decision-making needed to be done as soon as possible, there is someone who can respond. I would love to have RB board that consists of wizards. It doesn't mean that they all need to look at this guy on the picture. It's just, I would love them to be experts and knowledgeable. We know that in many organizations we have rotation, but this is what I'm thinking, that expertise is extremely important because we are asking multiple questions to get the guidance. We need someone to show us the path. Where to go. We need someone to share some expertise, probably bring a different point of view, and we need some magic spell that will help us to speed up the review process or have grant applications signed in timely manner. And the last thing, I think what is important, ideal RB will bring a peace of mind. I remember I came to one of my sabbais with some source documents where some check marks have been missed. And she looked at me, smiled and said, "Oh, I knew you will find everything that I have missed." So it is so amazing to know that there are people somewhere in this world who will be looking for your check marks. It's not something that I'm trying to miss them, but we're all humans. Just knowing that there is a shoulder that you can support, like rely on, just knowing that you are not alone. So I know that many things needs to be improved, but thank you that you're there for us. That's all.
Thank you so much, Tanya. And you're not alone. I have so many stories that I think I've heard at our site here in a different health authority from where you are that resonate with things that you had to say. So there is a community of like-minded people, and the more years that I do this, the more I see how big that community is and how we are approaching it from different sides, from being a patient or a participant or a researcher or a research coordinator or an REB member or an REB administrator. We all want the same thing. We all believe in the value of clinical research. That's why we're here. You said a couple of things I thought were really lovely. You said that community is stronger than a disease. And I think all of those people we mentioned, and I probably missed some, privacy teams, contracts administrators play into it. That community of people that is working towards excellence in research and excellence in patient care, they are stronger than diseases. And you reminded us of that. Thank you. I also liked how you noted that each phase of the life cycle of a clinical trial has ethics involvement. That is something that when we, as REB administrators, when we're chasing down someone whose study has expired and eventually we learn that it closed 6 months ago and they just forgot about it, it's a little disheartening, but that's the outliers. The norm is people who understand, probably because they have colleagues like you, that ethics is part of the whole life cycle. And the last thing I want to comment on before I turn it over to the floor is that Marie talked about how to simplify consent forms using diagrams. You had a diagram showing the life cycle of a clinical trial. What a great way to simplify things. You're providing an example, and I don't know if it was easy for you or hard for you to create, but you did it. And so it's doable. And perhaps if somebody out there is thinking, well, I don't have the skills, I don't have Visio, I don't have what have you that I need, then they can find someone on their team. Getting back to your comment, community is stronger than a disease. So many thoughts. I'm going to stop talking now, and I'm going to be looking for questions. First specific to you, because everyone else got that, and then if there aren't specifics for you, I'm going to ask. Well, I see all of our panelists are ready to respond. So let's just take a look at what we have in the Slido. So these are questions from the previous presentation, and I will do a quick check in the chat. Thank you, Aoife, for doing that. Maybe I'll refresh my Slido and just see if the same things come up on the top. And yes, okay, so we are going to go, so speakers, if you're ready, Terry, I think there's a couple of comments in there that might even be appropriate for you. So I will read out the questions in the order of the votes that they have. So this is your time to pretend that we're on reality TV, and you can upvote your favorite and keep them at the top of the island, to use a terrible, terrible metaphor. The first question, I would appreciate hearing from REB members and reviewers thoughts about why deferred consent as presented here might not be possible. So general question, and I think that's open to our audience. I cannot see all, we've got a lot of participants, wow. So I can't see everybody, but if you raise your hand, I think you might go to the top of the queue and I can address you. Do we have any members who would like to speak to that? I am not seeing hands up at the moment.
We have Jessica Agliari.
Oh, fantastic. There, I had scrolled away. Jessica, the floor is yours.
Hi, Dorothy. Sorry, I wasn't sure whether I was going to be turning my video on or talking in the chat. But so right now we can't do deferred consent, even a verbal consent. So because of Health Canada Division 5, it specifically says that written informed consent is required before a research study procedures start. So that's part of the complicating factor there. That's it. Anyways, good talk, everybody. It's really interesting.
I think Marie might have something to add to that. Go ahead, Marie.
We can, in actual fact, use deferred consent. The ACT study was approved by Health Canada to use deferred consent, as is the Frontier, which is another stroke study looking at neuroprotection. So yes, we can use deferred consent. We just have to meet the criteria that is outlaid in the TCPS2 and Section 3 on consent. So yes, you can use deferred consent, and you can use verbal consent. There are definite guidelines surrounding that, but Dorothy and I have had discussions about that, particularly when we got hit with COVID and we were going to be doing COVID trials.
Yes, COVID really kickstarted some things that ended up being good things. So terrible route to get there, but we had to go through it anyway, and we got there. I see another question in the Slido, another general question. So I'll put it out to all of our panelists and the floor. When is informed consent about the REB approval, and when is it about the legal protection for organizations or sponsors? Oh, Anonymous, you asked a tricky one, didn't you? Would any of our panelists like to tackle that one, or any of our audience members? Oh, Marie, yes.
I would like to say that it's always about the patient or the participant. That should always be our single most important guiding principle. As most institutions and departments have enough protection in place, and I'm suspecting maybe you're referring to a legal suit or something. It states that right in the informed consent that they do have the right to sue. So that also means on the other side that the institution and research, whatever, they're covered. It's already embedded in their legal protection, and I'm probably not using the right terminology. So again, I would state that it should always be about the patient.
Thank you, Marie, for bringing it back. And I know that my board and probably everyone here today agrees with exactly that sentiment. I will take a few more questions from the Slido. So the next one is, what barriers do you perceive exist currently to using these solutions to obtaining consent? Your processes are already permitted if submitted in application. Yeah, it's a tough one, isn't it? But barriers, perceived barriers to using some of the solutions that were suggested in the four of you, your presentations.
Can I just jump in here, Dorothy? Sorry.
Of course. Of course.
I'm just thinking about how I took it from their presentations that they weren't talking necessarily about perceived barriers to those approaches, but how maybe we should be thinking a little bit differently about making them a little bit more common and a little bit more easily accessible as options. And knowing as well that we do have that confounding problem of regulatory, Health Canada, what it says then under, and then under the ICH GCP and then TCPS2, which all kind of are the same most of the time, but so there are changes going on in one area. And so I just think that it's more about not necessarily that our speakers were talking about there was potentially barriers to these approaches, just like this is a really new way to think about certain things for accessibility. And I'm thinking about Tiffany's in particular with regards to distance and making sure that we have clinical trials more accessible to people that are not necessarily located in the busiest centers.
Well said, Terry. Thank you. And I have to say that just offering up one person's perspective out of the 100 of us that are here today. I've been doing this for 11 years. I did it for 3 years at Providence a number of years ago. And the difference between how things are managed now compared to how they were when I started, even here at Interior Health in 2011, and certainly how things were done in Vancouver 20-ish years ago when I was at St. Paul's. Yeah, 20, my goodness. It's like night and day. And that is a lot of things. I mentioned that COVID really accelerated the ability to work remotely and do things remotely. We're not 100% there yet, but we got a big old push and things rolled out, in our IT departments, the ability to do things remotely. The number of people who have patient care visits and telehealth visits is just astonishing. And that work was underway before, and it went into warp speed in March of 2020, and here we are today. So there's progress being made. I think we're talking about a big, important enterprise that is research. And so when I mentioned earlier the Michael Smith Health Research BScN and its component organizations or arms, I think they have a bit of a bird's eye view, and the Ministry of Health has a bit of a bird's eye view on how we can bring things together. But we're huge. We're just one health authority, and we have over 20,000 employees and physicians. We cover territory the size of Idaho. We have rural and urban, and we've got tertiary hospitals and little clinics that are staffed by one person on an overnight, and everything in between. So there's a lot of challenges to overcome just by virtue of geography, by virtue of technology and implementation of technology, and by some barriers that I think I've heard Alex Catch, who's the neurologist that Marie McClelland works with closely, talk about these things like they should be solvable. And I would say they are solvable, but we really need to be patient and perhaps take a look back at how far we've come. So I have a couple more questions in the Slido. And this one, I think I saw a response in the chat earlier, but the chat has grown long and I don't have the answer. So I'm going to put the question out there again. Has there been consideration of secure FDA e-signature compliant user-friendly tools such as DocuSign? So there was a comment, someone made a comment earlier about DocuSign, and perhaps if one of our panelists doesn't have a quick answer for that, perhaps the person who was commenting on DocuSign or anyone who is tech savvy and knows the ins and outs of it could address that.
I tried to reach our privacy department multiple times because it will save so much time on scanning, waiting for PI to come, and etc. Or going to another hospital to get signature from another sub-I. However, as any IT software needs to go through the privacy review. So within a year, no progress. If there is any other software already approved, nothing is approved. It's in Fraser Health.
And I'm just looking to see if there are any other comments on this quick question. And seeing none, I will move into currently the last question that's in the Slido. When mailing consent forms, do you also include the envelope and the prepaid stamped or FedEx for the patient to use? Yes, Marie's giving the thumbs up. I think that's pretty standard. And if it isn't, it probably should be, because it's a fairly small thing that goes back to what Tiffany said and what all of our panelists today have said. They're very, very good at putting the patient first, at removing barriers, at making the process easy and taking away those barriers. That's one way of taking away a barrier. So Tiffany, I see you nodding. You talked about that. And I think that that's what we all want to do. Ultimately, we want to take away the barriers that disease cause, and clinical trials are a way of working towards that. So anything that we can do to facilitate, that's one example.
Yeah, and sorry, Dorothy, I just want to touch on that. Even though it seems like such a simple thing just to include a return envelope and with it obviously stamps on it, I've had some patients where, you know, for whatever reason, a return envelope didn't get mailed out to them, and it will literally take months to come back. And this was for biobanking stuff, so it wasn't as time sensitive, but just for them to find an envelope and for them to also find a stamp can be huge, even though it doesn't seem like it's a huge barrier, but it definitely is.
Mm-hmm. Yes, it's I'm reminded of something that I heard an educator of little children say to them that I loved. It stuck with me for years and years, and this was in a religious environment, but the phrase that this person started with was, may the Lord be with you where you are at. Now, if we take that into our secular clinical world and put ourselves where our patients and where our participants are at, then we can identify the barriers and maybe find a way to eliminate them before they present themselves. So in whatever manner that you adopt that phrase, I think patient-oriented research is all about what I heard years and years ago. That's just the wording that has stuck with me. But I think that all of our presenters today are really embodying that in the way that they've described their work. We just have a few minutes left, and oh, there is one more question. So I was about to turn it back to Terry. Let's just read this question. Harmonization of industry-sponsored trials could significantly shorten review timelines. How do the panelists feel about moving towards more harmonization? Oh, Terry, I think that that's probably a good question for you too. But Marie, you have your hand up. Please go first.
We've participated in harmonized trials before, and we actually have a couple ongoing. One of the biggest problems with it is that if the site that is the originating site is then expected to be the repository for all SAEs, all regulatory, all protocol deviations, that sort of thing, that is an unrealistic and huge burden to put on that one originating site. So yes, I like the idea of harmonization, but we've got to have a division of labor, and it cannot be that, like it's ridiculous to say that a qualified investigator in Vancouver is also the qualified investigator for Kelowna. When they have no privileges here, they don't understand how the inner workings of our department and our hospital go. So there's lots of things to be looked at there. I agree with the philosophy of harmonization, but put into practice, it can be very, very problematical, and it can create more work.
I'm just looking to see if there are any other comments on that topic. And
Can I
oh yes,
please?
of course, please.
We are located in Fraser House, and there is another MS clinic at UBC, and it happens that the manager there is a good friend of mine, so we work together at one time. And it doesn't mean that we always have the same projects. That is why it's not always possible to have harmonized studies. But it just happened that we recently set up the same project, and I was a little bit ahead and she was setting the same project after. There were some questions from the UBC RB that were already addressed on my end. It was just exchange of the information. I just shared the consent forms and we discussed, so it definitely helped to speed up the process. So probably harmonization cannot be done partially, I don't know, at least initial setup phase, if it's so complicated, and then each site will be responsible for their own regulatory and other things. That will be helpful, I think.
I think there are some improvements that could be made to the technology that supports the harmonization with regards to, specifically for clinical trials, to allow the sites to be able to operate separately, but have an advantage of having the centralized document storage in order to not have to repeat the same process and send the same forms, or share the fact that you've already got approved consent forms that have gone through the BC lens. So that's, I think that is something that we are looking at, and hopefully will come soon. Well, soon is a relative term. I'll stop there with that. But on that note, we are coming to a close. I just want to say thank you to all of our, well, first of all of our participants for being here today, and especially to our moderator and all of our very expert panelists. You've really done yourselves proud by creating presentations when we know you're very busy people, and taking some time out of your schedules in order to share with us some of your thoughts around where we could maybe have more consistent processes and help you to do your jobs. And I love how it's been pointed out that the research ethics is a part of the whole clinical trial process from beginning to end. And so that's very valuable for us all to take away from here. And so I just want to say thank you to everyone. This does bring us to a close for our whole clinical research ethics symposium for 2022, which has gone swimmingly well. And so I'm really, really pleased with not just with the turnout, but with the quality of the presentations. And I want to give a great big shout out to the organizing committee. So we collect volunteers, and some of them we put into the roles of moderators as well. So we had volunteers from within our Research Ethics Board Administrators Network that we asked to be volunteers for creating this conference. And they come up with the ideas and the speakers, and they do the solicitation of trying to help us find interesting people to bring here. So thank you very much to our organizing committee. And I want to say a special thank you to my team as well, Rachel, Aoife, and Jessica, for doing all the legwork in the background so that I could actually just really enjoy the speakers and the presentations over the last 2 days. So thank you very much. And I just want to give you a real good shout out for that. We are going to be sending out surveys, and we're going to ask everybody, please let us know your thoughts. That'll give you an opportunity to let us know what you thought best about the symposium and ideas for future events, as well as an opportunity to volunteer if you'd like. So please stay tuned. We will be starting our roundup of volunteers for organizing REB West, which will take place hopefully in June and hopefully in Kelowna, barring any snow. And with that, I'll wish you all a very good day and a great weekend. Thank you so much.